Hello, my name is Jeff Hostetter. I'm a physician and director of geriatrics education at the Bismarck Center for Family Medicine Residency in Bismarck, North Dakota. I'd like to talk to you today about limits to accessing healthcare for American Indian and Alaska Native people. Many of these limitations have been discussed widely, and some of them hopefully you haven't thought about, and uh, we can give you some food for thought in the future tonight. By the end of your time today, I'd like you to have a better understanding of the history and current structure of the Indian Health Service. We're going to start with a very brief overview of how the Indian Health Service came to be in the United States. And then I'd like you to describe 5 systemic barriers for people who access healthcare through the Indian Health Service. The Indian Health Service got started actually under the treaty system. In the 1700s, healthcare was considered part of payment for what they termed appropriated lands when the U.S. Army would defeat a tribe in battle. In 1787, Congress, the Constitution was amended to give Congress the power to negotiate with Indian tribes. Before that, there was no legal basis to do so. Between 1789 and 1849, the War Department was responsible for Indian affairs. In 1832 was the first time the War Department was given any extra budget to provide health care for American Indian people. They were given $12,000 for smallpox vaccinations. This was after it came to light that the military had given Native populations in the West smallpox-infected blankets, and the general outcry among the people in the United States, as well as some very active voices in the American Medical Association, resulted in this appropriation. Problem was to get treatment, to get a vaccine, you had to actually go to a military hospital in a fort, and getting people to trust the soldiers who had tried to kill them just a few months or weeks earlier was a difficult proposition, as you can imagine. In 1849, the problem with the War Department being in charge of Indian health became apparent, and the responsibility for providing Indian health was transferred to the Department of the Interior. Bureau of Indian Affairs was formed in 1911, which is almost 80 years after the initial budget. They had a budget of $40,000 for the entire Indian population in the United States in 1911. In 1921, the Snyder Act was authorized, and you can read the quote. They're about to help relieve the distress and conservation of health of Indian people. Those of you who have studied the Snyder Act also know that it was used as a basis for cultural genocide in many cases as well. In 1948, so 27 years later, the Hoover Commission and the AMA again kept pressure on the government, transferred the BIA from the Department of the Interior, which is the department that deals with national parks, to a more appropriate cabinet office in the U.S. Public Health Service. The U.S. Public Health Service, which resides in the Department of Health and Human Services. Interestingly, the budget was not transferred and still has not been transferred. So the Indian Health Service is the only department in the Office of Health and Human Services that doesn't have control of its own budget. It's actually controlled by the Department of the Interior to this day. The U.S. in 1954, the Public Health Service Corps was transferred to the Surgeon General. In 1955, the formal Indian Health Service was established. There were 48 hospitals, 18 health centers, 62 stations, rural aid stations, and 32 school infirmaries at boarding schools that was under their control and management. By 2020, the number of hospitals had dropped significantly, as is the case in most parts of the United States. The health centers, though, increased from 18 to 51. There were only 24 health stations left. Most of those had been taken over by tribal health programs at this point. There's still 12 school health centers and 6 youth treatment centers. 1975 was you could consider a watershed moment in Indian health. President Nixon signed the Indian Self-Determination and Education Act, better known in some circles as Public Law 93-638. This allowed American Indian and Alaska Native tribes to assume operations of their own health service that was, for the most part, outside of IHS control. The IHS still provided funding, but all of the rules and regulations that hampered the IHS from providing culturally appropriate health care were alleviated when tribal government has the authority to run the hospital and the health system on their land. In 2020, there were these listed 638 programs, most notably their Alaska Indian Village clinics, which are exceptionally remote and can't be run by the IHS due to many barriers. But there were 279 health centers, so many more local and smaller healthcare facilities that would take care of individual needs of individual populations. 1976, there was the American Indian Healthcare Improvement Act, which allowed the formation of urban Indian health centers because actually the majority of people who are indigenous live in urban areas, not in rural reservations. There are 41 of these urban Indian health services, Indian health centers in existence as of 2020. So I want to talk about, now you know kind of where we came from. Let's talk about barriers that exist in the Indian Health Service. One of the barriers is a mismatch of the distribution of resources versus the distribution of the population. As we talked about earlier, there are 41 urban health centers, but still many, many more facilities on the reservation, yet 2.2 million of the 3.71 million American Indians in Alaska, the distribution of the population is 70% urban, and only 25% of them live in counties that are served by an urban Indian health program. Indian Health Service remains a significant source of health care for Indigenous people. 2.2 million of the nation's 3.71 million people get care through the Indian Health Service. And the only way that this can happen is if they drive to the Indian Health Service facilities from urban areas, or if they just overwhelm the urban systems, because the majority of people still are not living on the reservation where they are entitled to care. Barrier number 2 is control of funding. We talked about this a little earlier. Budget is managed by the Department of the Interior, which causes lots of problems. There's a shortage of medical staff. As you can see, there are only 700 in 2019. There were only 776 physicians to take care of those 2.2 million people. There were 104 advanced practice providers, and the engineers and sanitarians are on this list because IHS is in charge of water purification in many places in the country. There's inadequate funding. You can look at the details of this slide in the provided slide set, but you can see that congressional appropriations, third-party collections do make up a significant portion of the budget. However, this doesn't cover the costs, as we'll see in a moment. And Congress approves the budget for the IHS yearly. There's not a way for them to expand that budget. Medicare can go over budget, IHS cannot. And so if you have a particularly bad year, it is very difficult to get extra funding for unforeseen illnesses or circumstances. In 1924, law was passed that stated that people who could be covered by the Indian Health Service can also be eligible for Medicare and Medicaid. This is something that it seems many politicians and much of the general public doesn't know and has caused some problems in North Dakota. Per capita spending in 1997, the Indian Health Service spent $1,430 per person providing care. The Veterans Administration was $5,500 approximately. The Bureau of Prisons in the United States spent $3,500. So we fund our prison system better than we do the Indian Health Service. They got a little bit better, but not much. By 2015, you can see that yes, we almost doubled the amount, or we more than doubled the amount we spent in the Indian Health Service, but we also more than doubled what the VA got. So the disparity got even bigger. 2019, it still remains there's a huge difference in the total population of the United States. We spend about $9,700 per person on healthcare. That includes really sick people and people who never access healthcare, except in emergency situations. And the Indian Health Service only spends about $4,100 per person. Barrier number 5 is accessing advanced care outside of the IHS clinic. There are lots of rules that have to be followed in order to access care outside the clinic. If a service is provided at the service unit, you have to use it. You don't have a choice. Don't get to choose which hospital or which doctor or anything. You have to go to the service unit if it's provided. And if it's not provided, you have to go through the contract health system. Contract health system is very complex and grossly underfunded. It's about 20% of the Indian Health Service budget, and care has to be prioritized. And additionally, if you would qualify for alternative resources like Medicare or Medicaid, even if you're not signed up for it currently, if you would qualify, then you're not eligible. Contract health services funding is usually exhausted before the next fiscal year is done, and the priority system for the Indian Health Service makes it so that priority 1 requests usually exhaust all of the funding, and you don't get other things like total hips and total knees at the end of the year, since those are priority 2. This isn't true for all years, but for some years. If you do go to some other problems with the contract health service system is that the outside hospitals and clinics end up absorbing cost. because people go see them without contract health approval, and then contract health says, well, we won't pay for this because you didn't get it approved first. And the other stance of the Indian Health Service is that due to the Hill-Burton Act, hospitals are supposed to write off a certain amount of their care and just give it to Indigenous people. And that causes lots of problems, as you can imagine. The rules to navigate the system are incredibly complex, and patients end up with huge debts because of bills that aren't covered or denied by contract health or other administrative problems. So those are some of the barriers that I'd like you to think about that typically we don't think about. If you want to look up further information and facts about the Indian Health Service and care that's provided by them and tribal clinics, you can access some of these resources. If you would like to be involved or know more about the inner workings of the Indian Health Service, the U.S. Senate Committee on Indian Affairs website is here. Thank you for your time, and I hope this was informative.